Welcome to the Innovation Accelerator podcast, brought to you by Innovaccer, the health cloud company. We're on a mission to connect and curate the world's healthcare information to make it accessible and useful. With Innovaccer, everyone works in the service of patients like never before as one. Visit us online at innovaccer.com.
Welcome back to the Innovation Accelerator podcast. Today's show is going to be a new experience for our listeners and viewers because on this episode, we're bringing three hosts for just our one guest. It's similar to the TV show The View. And speaking of views, today's guest is no stranger to sharing his, a nationally known healthcare thought leader who's been repeatedly named to modern healthcare's most powerful persons in healthcare. Dr. David Nash is the founder of and Dean Emeritus at the Jefferson College of Population Health. And Dr. Nash is a board-certified internist who's internationally recognized and often quoted from his work in healthcare accountability, physician leadership, and quality of care improvement. Along with co-author Charles Wohlforth, Dr. Nash authored the soon-to-be-released book, How COVID Crashed the System, a guide to fixing American healthcare. With a release date set for mid-October, the book has already received a lot of recommendations and praise from some of healthcare's top leaders. And on a high level, it's framed in two parts. In part one, the authors provide a wide-angle analysis of how the world's most advanced and expensive healthcare system, in many respects, crumbled during COVID. And the authors go on to highlight a number of core areas of failure with extensive research. Part two of the book shares a silver lining playbook, delivering a blueprint that's filled with numerous insights and action steps to improve our nation's healthcare system. Our show hosts, who will be interviewing Dr. Nash about the new book, will be myself, Dr. David Nash, Chief Medical Officer at Innovaccer, and Dr. Brian Silverstein, Chief Population Health Officer, also from Innovaccer. And we'll be going by first names on today's interview. Dr. Nash, David, it's an honor to have you on the show with us, and congratulations on your new book. We've been looking forward to speaking with you for quite some time, and we're really glad that you could make this happen.
Well, thanks so much, Steve. Great to be together, especially with some of my best pals, and I really appreciate the opportunity.
Us as well. And before we get started, if you could please tell our audience a bit more about your journey and how you got to this point in your career, and then also why you decided to write this book along with your co-author.
Look, I've been on the full-time faculty at Jefferson for 32 years now. This has been my professional home. I've only had 3 jobs over 32 years in one place. My grown children think that I'm a walking, talking dinosaur. They're probably right, Steve. So I was a pretty focused individual who knew in high school that I wanted to be a doctor and that I wanted to be a different kind of doctor, what I thought back then, some kind of physician executive. So I'm incredibly lucky that I was able to sort of make that vision come true, and all the great leaders at Jefferson helped me. But with regard to the book, so I met Charles Wohlforth before the pandemic at a conference in New York. Seemed like a super nice guy. Actually gave me one of his books to read. And I just thought, great, nice to have a new friend. Then we were in 6-7 months into the pandemic, and Charles reached out to me and he said, we should write a book together. Your voice, it's really important. What's going on? I can't believe it. And honestly, at first I was reluctant and ambivalent and a lot going on. And he said, no, we got to do this. And so special thanks to the amazing and award-winning co-author, Charles, who basically very politely twisted my arm. And the main reason that I wanted to do this beside Charles is convincing me was, look, I couldn't make a contribution at the bedside. That's for young people like attending physician daughter. But for me, I thought I could make a lasting contribution by writing this book because it was a unique moment in history. And I thought, well, for me, I can't be at the bedside, but I'll use my most powerful weapon right here and the written word to get the message out. So it was a very personal decision. Charles helped me to crystallize it, but it was my way of saying I can still be at the bedside, but with a megaphone to talk about the crash and what we could do about it. So that's my perspective.
Yeah, and you certainly do that in the book, and we'll be talking about that. One more thing before we get started, I do want, if you could, to please give a nod to your family members who you do also mention in the book.
Sure.
If you could just mention a quick
sure.
Shout out to them.
I'm sure they'll be thrilled, Steve, but sure. So I'm married to a doctor for 42 years, Dr. Esther Nash, who just very recently retired. I have 3 children, one of whom is an attending physician, one of the youngest medicine program directors in the country at Cooper Medical School. She figured prominently into the early part of the book. I have 1 kid brother. He's a doctor, married to a doctor. And my wife has 1 kid sister. She's a doctor, married to a doctor. So we could have like the Nash Clinic if we decided to ever do that. But yeah, it's a pretty unusual situation, I admit. But yeah, obviously I couldn't have done this without their support. So, special thanks to all of them for sure.
Fantastic. And I'm going to go ahead now and hand it off to Brian to get us started.
Absolutely. So excited to be here. And just, again, what an amazing book, such interesting stories. And as I was reading the book, one of the things that I personally really enjoyed very much so was hearing about your family members that you included. And obviously I've known them outside of the book, but then hearing the stories in the book. So I'm curious, those personal stories really brought this to life. I'm sure you had conversations with Rachel and S and everyone about this. What were their feelings about including them as such of a key role in the book?
Yeah, wow, Brian. So I got to be real careful here to keep the 42-year relationship going, right? So once I dove in with Charles, I said to Esther and to Rachel, I said, look, Charles wants to interview you. I hope you'll agree. And actually, to my personal surprise, they not only agreed, but they were enthusiastic. I think they thought maybe they could humanize me a little bit. Great. And they had their own really important contributions to make that Charles, wove this fantastic thread throughout the book. So one was they were doing me a favor, and then I honestly think they really enjoyed it. And I hope that they'll be pleased with the final product too.
Did they have any editorial?
Yes, well, of course. My 2 greatest supporters and among my toughest critics. Let's leave it at that for sure.
Fantastic. Something else in the book that just really, struck me that I, had heard from you before, but again, seeing it in writing just had such a strong impact was about in the beginning of the book when you're talking about your service for the mainline board, and specifically one of the things that was touched upon in the book, but just wanted to perhaps bring it a little bit more to life, was your role on the quality committee, and specifically in bringing in family members that have had an adverse event. And maybe if you want to just share a little bit more about that, because I think that really it encapsulates a lot of the power of stories to bring about change.
Right. Well, as you guys know, storytelling is what it's all about. And that's how grown-ups learn. And remember, it's not what you tell them, it's how you make them feel, right? That's the message always. Well, look, I've been a hospital board member in my career for 20 years, 10 years at Catholic Healthcare Partners, now Mercy out of Cincinnati, multiple states, scores of hospitals. And I followed that pro bono service at Mainline Health, which is right here in suburban Philadelphia, for almost 10 years there as well. And I was only the 2nd chair of the board quality of care and board safety committee. And along with tremendous support from their amazing CEO, Jack Lynch, and the entire board for that matter, We had at least one opportunity, maybe two times, where we brought families of patients who we had harmed to a board meeting to meet the board members and really, Brian, to make it real, to personalize it, and to some extent to listen to their story so that we would really get a deep human understanding of what had happened. And I think, very importantly, to further our commitment to improve quality and safety of care. Because as you know, and as I'm sure our listeners appreciate, it's the board that bears the ultimate fiduciary responsibility for quality. It's not the hospital president, it's not the medical staff president, it's the board's responsibility. So when they met those patients and those families, it made it very real to them. And honestly, I've had this experience at Catholic Healthcare and at Mainline and in other settings. It's incredibly powerful, incredibly powerful.
So I'll jump in, David, and I want to ask, in part one of the sections that you outlined is the failures of leadership as a part of one of the core lessons that we can learn from COVID. And in the book, you're pretty transparent on, I would probably say, your criticism for former President Trump, and in particular his role in COVID and negative contribution towards it. And I want to read a section from the book's chapter here. Quote, with over 800,000 dead, that estimate suggests the administration was responsible for more than 350,000 excess lives lost. The real number can't be known and it will long be debated, but we cannot proceed to our systemic investigation of America's COVID failure without looking at the malfeasance of the one man most directly responsible for so much suffering and death, President Donald Trump. If you could break down the top failures related to and caused by President Trump during COVID, what would they be?
Well, look, we didn't write the book as a political treatise. I get it. And I know there's strong feelings on this issue. We're just going to rely on evidence as we saw it happening and as many others have written. So, just in quick chronological order, people don't remember because why would you? Remember, Trump was flying home from meeting the Prime Minister of India and had been informed by the CDC, by courageous people below the director level, to prepare for a national emergency. Not only did he poo-poo it in the earliest period, he wanted those people fired. Remember, too, that he was surrounded by people who were, in many respects, unwilling to challenge his authority, were really not going to press the science on him. And I'm sure our listeners remember that, look, let's all go to, if you would, Easter Sunday, the very first Easter of the pandemic, and I'll see you then, and everything will be fine, and we'll have a miracle, and it doesn't affect children. I mean, it's hard to even stay calm discussing it. But what the final blow for Charles and me was the brave editorial, for the first time in 150 years, that the editorial board of the New England Journal of Medicine in October, before the election, understandably, wrote together a piece that said they just had to point out that you could attribute the failure and the deaths to leadership under, at that time, President Trump. So I just thought, well, the historical record is very clear. From the very first moment he learned about it to poo-pooing it, then, trying to get Vice President Pence to be the voice because his, Trump's press conferences were just so quite unbelievable. Let's not forget swallowing bleach, which people then went on to do. So, but the final blow for us and why we put it in the book and why it's so critically important is we had opportunities that other world leaders took very seriously and that he totally not only ignored, but disparaged. and the New England Journal of Medicine editorial board about the best brains in the business, saying that this was a colossal and unprecedented failure of leadership. That's why it ended up in the book. And whatever your politics, quite frankly, it's irrelevant. I mean, the historical record stands as is.
David, that's a great point. And let me pick up on that. We have a unique country. We are the United States of America, not a centralized government such as China. So say a little bit about why you believe that national public policy organizations, the actual states themselves, couldn't step up and override what you just described.
Right. So great question, David. Again, just wonderful to be part of this. So as we point out in the book, there are sort of three additional themes we talk about, right? Federalism, exceptionalism, and individualism. So in our very heterogeneous country, the states' rights versus the central government, we had no centralized medical care system and certainly no national public health system outside of agencies like the CDC and HHS and the NIH. So there was no countervailing power, no ability to say, no, this is wrong. Here is the scientific evidence. So certain people stand out as, being courageously attempting to get the message across, of people like Dr. Fauci, Dr. Birx, to some extent, Dr. Redford. But, again, their voices were sort of muted because there was no centralization. Federalism is a very powerful part of our culture. And the fight that governors had to get resources early on, one governor pitted against another. I mean, there's written, again, evidence that certain governors used the National Guard to protect ventilator shipments to their state, or use the National Guard to go get masks from another airport. I mean, crazy stuff. So I'm not a proponent of a, centralized communist government like China. Certainly not. But these themes of federalism, exceptionalism, individualism, they did not work in our favor in the setting of a major, unprecedented national healthcare emergency. So looking into the future, maybe we'll have a chance to chat about it. We're going to need a better process next time. And, lots of smart people tried, but it was a disaster. And it's easy to forget, just how scary that really was, especially in the first 7 months.
Those are great points. And there's a structural aspect. And you do illustrate the points of some countries that were more centralist, like Asian countries, Scandinavian countries versus us, who tend to be a little bit more individualistic. But there is this concept of American exceptionalism, right?
Yes.
And it's the enigma that we have with pockets of excellence and yet a country that doesn't deliver adequate healthcare. Can you say a little bit more about those cultural drivers?
Sure. So the exceptionalism that we talk about is basically exactly what it sounds like. So we are the exceptional country. Why would we ever pay attention to an island nation like Australia or New Zealand or the UK? Or how about our colleagues in Italy who in December of 2019, Christmas 2019, phoned the doctors at Jefferson, where we have a close relationship with the leading hospital in Rome, to say, you have no idea how serious this is. It's coming your way. Get ready. And fortunately, the leadership at Jefferson did not practice American exceptionalism, right? And they were much more open-minded because we had personal relations with these amazing Italian physicians and leaders who said, you're going to need more PPE than you ever thought possible. Get ready. It's coming your way. It's unstoppable. So that exceptionalism writ large across the country, played out. So there's no arguing. If you were in a state with a red governor versus a blue governor, you had a higher mortality rate on average if you lived in a state that was a red state. And this is complicated by access, politics, masking, all the rest. But American exceptionalism, I wish we had paid closer attention to many nations that created trust. That seemed to be the central theme. In nations where there was trust in the government and trust in what they were being told, people, the population, generally speaking, was more accepting of the lockdown, of mask wearing. Oh, and by the way, had higher initial vaccination rates. So, David, I think it's exceptionalism, it's federalism, it's individualism. I always like to say, and we talk about this in the book, look, it's part of our culture that we're in the covered wagon, we're heading out west, we're going to defend ourselves from those Indians, crazy stuff, but it is part of our culture that you can't tell me what to do. And I live in this great country because of that individualism. My interpretation of it is I am a patriot and Charles is a patriot. And that patriotism means that based on the science, we're going to tell the truth. That's what patriotism is all about.
David, you mentioned trust from the last answer here, and I think it's a great segue into this, which is in the book, and when you're discussing in part one, the different areas, the problem areas that became more exposed through COVID. One area that you tap into quite heavily is the section on COVID as it relates to and opens up greater insight into racism, structural racism in America. Yep. And I'd like you to two things here, if you could. I'd like you to share a bit more about that on a higher level. And then one of the more inspiring stories in the book was on Dr. Ayla Stanford and her efforts. And so if you could also share a bit about her and what her efforts meant to COVID and to her community.
Sure. And understandably, these remain a year and a half later two very hot button issues. So let's just put that out there. Well, look, I certainly, and Charles and I are not the first people to describe this. W.E.B. Du Bois, over 100 years ago, just after the Civil War, described in his classic work, The Philadelphia Negro, published in 1897, the problems that people of color are facing. And here we are, a century and a half later, with the same darn issues. So structural racism, housing, poor public education, food deserts, redlining, all of that played a huge role. And all COVID did was shine a bright light on stuff most citizens had some basic understanding of. But now with the pandemic, shine two spotlights, maybe even three, on these dreadful problems. Let's just look at Philadelphia for a moment. So 1 out of 4 people lives in poverty in our great city. If you look at the nation's top 10 cities by population, we're like 4 or 5, depending on whether Phoenix is counting or not. Of the top 10 cities by total population, we are the poorest. So why did the airplane crash? Well, of course it crashed because poverty in the United States equals poor health. That's a very sad state of affairs, not a new state of affairs, sadly. But I think COVID made that connection so clear to folks. And then when you try to dig a little deeper, let's look at New York City, crushed by COVID, especially brown and black hospitals in poor neighborhoods. Well, no surprise. Fewer resources, less access, no primary care. What else is going on in the community? Well, they have poorer health to start with. So in Philadelphia, obesity, cardiovascular disease, diabetes. Oh, and then let's look at how they're employed. So these are people who don't have a paid day off. When they're sick, they got to get food on the table. You got to work. So who died early on were cooks, bus drivers, delivery people, people who couldn't take a day off. I mean, when you think it through, it's like staggering. How could this happen? in our great country. So when you spell it all out, it's a tough part of the book, admittedly, but I guess the punchline for me is structural racism is a real, palpable, dreadful, decades-long problem that COVID just said, here it is, and that's why these people die. And that's what we point out in the book. We didn't invent this. Look back to 1897.
And then as far as Dr. Ayla Stanford?
Ah, yes, Dr. Stanford. So, she's a folk hero here in Philadelphia. We're all super proud of her. I have a different view of this, which is, why? I mean, I wish we had 1,000 Dr. Stanford, right? I mean, the fact that she had to take vaccines in a truck into the Black community is, to me, if you would, a failure of the status quo medical centers. Healthcare is the biggest business in Philadelphia, but it took a courageous person, not necessarily a part of the status quo, to call to our collective attention that we've got a problem in multiple zip codes in our big city, and we better do something about it and do it quickly. So she's a folk hero. As you know, subsequently, President Biden appointed her as the HHS leader in this region. So now she's a member of the administration and a very powerful political figure. I admire her. But on the other hand, I'm ambivalent. I mean, why did it take somebody with individual courage, like it always does in a crisis? Why did we need to rely on her to point out that this airplane had crashed? You don't need to get the black box to decipher what the heck happened.
I'd like to push back just a little bit on something you said there. I certainly realize that, and I think many people wouldn't argue the fact that poverty has such a direct relationship to quality of health.
Yes.
Certainly. But at some level, there's a trust issue. There was a trust issue that was at the heart in the African American community in particular that Dr. Stanford addressed, of why people weren't getting vaccinated. And, I think you go through it quite clearly, and it's a pretty riveting story of how she stepped up to recognize that and bridge that gap of trust, the lack of trust in the community. And, at some level, doesn't having to close that gap of trust have to come both from the institutional end, but doesn't it also have to come from people on an individual level as responsible citizens to recognize that, we're not living in 1897 anymore? I mean, things are not perfect by far.
Yeah.
But certainly the opportunities.
It's a tough issue, Steve. I mean, the poor are poor because they are, not ambitious. We've heard that for centuries. So look, I think when you sum up structural racism, poverty, crime, lack of fresh food, we know in pediatric research that this actually changes the genetic makeup of children who go through this kind of childhood. I can't possibly understand that at the individual level, but when you look at the research evidence, it's incredibly powerful and compelling. So I think the real answer, and what Dr. Stanford showed us, is, we need more caregivers, nurses, doctors, pharmacists, community health workers who look like the people who they're taking care of. Well, that's a gigantic challenge, which we address in the chapter on medical education. So again, what COVID did, it's like a snapshot with really bright lights, right? It said, look at this incredible problem. When you look at the root of it, the root of this in part was not enough doctors and nurses of color who could say to the leadership, hey, wait a second. People aren't just going to line up for a vaccine because Jefferson says it's a good idea. I mean, we learned that right away. And to our credit, and Penn and Temple and all the entire incredible 5 medical schools in this town, to their credit, it took a little while, but they pivoted, they got it. And folks were dedicated to getting the vaccine, since you brought that up, into the community. It was not an easy thing to do, for sure. But the root, I would argue, is structural and can't be cured and can't be wished away. That, I wish the poor would participate more in their care. Look, let's make it really personal. David Nace, Brian Silverstein, and I were trained a long time ago. Totally different than the training my daughter has received in medicine. I mean, I never asked a patient, do you have a refrigerator? Could you afford the car fare to come and see me? I mean, honestly, I was never trained about that. And I went to University of Rochester School of Medicine, where George Engel wrote the textbook on understanding patients and asking them the social, political questions. Well, I think we've made some progress in the new generation of doctors who this is second nature for them. And now we have all kinds of disruptive primary care companies that are in these communities asking these questions. So we're making some progress, but I think from a senior physician leadership perspective, most of this is probably new news to them. All you have to do is look at the leadership at JAMA and what happened in the last year as a great example of, more than a slip of the tongue, that there are no racist doctors, so how could there be structural racism? Well, we all know what happened there. So this is a complicated question. White guys who are over 65 are not going to solve the problem.
And just to build upon that, it's interesting when you look at what you were referring to, David, adverse childhood experiences, ACEs. This has been well studied and documented for decades. And certainly those early childhood experiences have almost unexplainable impacts on disease later in life. They're the strongest predictors, and that's been known, and we don't even ask about those today.
Right.
And then the other thing that you look at that really is just, starting to shine a light on this is the data looking at differences in outcomes of patients based upon their race and ethnicity. Yes. And on the physician's race and ethnicity. And there's some health systems, specifically Meritus, they were very open about doing some research looking at their patient population and outcomes and variance based upon race and gender. And the results, are so striking. It almost appears that it can't be true.
Correct. Yes. Excellent point, Brian. And as you and I know, this is not a new issue. There's 2 decades of very solid health services research. Black patients get less pain control. They are not listened to in the same way as white patients. There's a famous case of COVID in a Black female doctor who indicted her own institution because they didn't take her care seriously. All the way down to, the pulse oximeter doesn't work in very dark-skinned people. Oh, really? Well, okay. Well, that changes a lot of what we're going to do for telehealth, and on and on and on. So these are not new issues. And again, this is what we try to bring out in the book. Is very powerful. This is like the third rail when you touch this topic, but it's not new. What COVID did is made it so crystal clear you can't ignore it any longer. That's really our point.
And David, just to touch on one other thing, you mentioned in your book as well that I believe the number you put out was 186,000 additional physicians in your estimate is really what would be needed to be able to reach, all people properly in primary and high levels of caregiving in order to really touch our communities.
And I have to interrupt you because I'm smirking. That's the key, but the key is primary care. And again, Philadelphia, Jefferson, Sidney Kimmel Medical College, and Drexel University College of Medicine. These 2 great medical schools are the 2 largest private medical schools in America. 1 out of 4 doctors passes through Philadelphia in 2022 at some point in her training, 1 out of 4. So what happens in this town is emblematic of what goes on around the country. So that's another big discussion. How do we get young people interested in primary care? That's a big topic in and of itself. And again, that's the root cause of what's going on. So access has to be improved through providing universal access and coverage, not universal, not single payer, but universal access, universal coverage, and more primary care doctors and other types of primary care givers. We know this. This has been around pre-COVID. What did COVID do? It crashed that system that was so super subspecialty oriented. It also crashed the system, which we describe in detail, of docs in private practice, fee-for-service private practice, who had to essentially close down for months on end. Many of them never economically recovered. Whereas doctors employed in systems, especially capitated, managed care systems, call it whatever you like, those physicians in a system where they were getting paid on a per member per month basis, they survived economically quite nicely. So structural problem leads to failure, totally predictable. When you don't have a primary care strategy, what did we think was going to happen? So that also was part of the crash of the airplane analogy. No primary care system. We got to work hard to build that for the future. So your question is great, timely, 186,000 primary care doctors. That's what the experts believe we need moving forward.
David, you've really weaved in there a lot of the aspects that caused our healthcare system to crash. And I think, as you pointed out in the book, that the healthcare system crashed when the market crashed. The market for healthcare crashed.
Yes.
And you talked just now about fee-for-service, capitation. You illustrate very nicely in the book the history of those two endeavors that led to groups like Kaiser Permanente and coming out of the World War II, and then also the fee-for-service system coming out of doctors in the 1940s, having to deal with both hospitals and doctors wanting a constant income stream, leading to the insurance industry and fee-for-service. Where do you think this leads us coming out of this market crash, this COVID crash? And particularly as we move into solutions, and you're talking about how do we think about incentives and your beautiful concept of the payvider.
Yeah, wow. So let's try to unpack a little of that. So just quick history lesson, which you sort of reviewed, David, that most folks don't appreciate. So what's unique about our country? Again, this is, exceptionalism and individualism. Well, we're the only developed nation in the Western world where most folks get their health insurance from where they work. That's a complete historical accident from the Kaiser shipyards going back to 1941, 2, and 3. And the tax, special tax payments, and so on. So that's a unique piece of what makes American healthcare work or not work, depending on your perspective. That's one part. The other part, as we just alluded to, COVID, when we had to shut the entire society down, folks who were making their living on the provider side on a fee-for-service, episodic, piecemeal basis, well, there was no access, no people, no revenue. So they had to close shop, lay off the nurses, etc. So in the book, we talk about a concept that, frankly, David, you and I have been chatting about since 2018 and 2019. We call it this clunky term, the payvider, or a integrated financial and delivery system. That's Jefferson's preferred lingo. I don't care what we call it. What we were after in the book, and in the chapter on health insurance, we even say to people, sorry, hang in there with us. It's turgid. But the message is, if you change economic incentives, something I've been interested in for my entire career here at Jefferson, 30 years of work on this question, we know if you change how you pay doctors, nurses, pharmacists, and hospitals, they're going to change their clinical behavior. Meaning, if you pay them to deliver piecework, like an RVU, fee-for-service, unbundled system, we're going to deliver piecework, and we're damn good at it. If you pay the system, doctors, nurses, pharmacists, to keep people healthy, lots of strange things occur. We go upstream instead of mopping up the floor and wondering why, the water is still on. We go upstream to tackle hypertension, diabetes, and cardiovascular disease, and nutrition, and exercise, and primary care, and care coordination. So if we change the economic incentives, we can change clinical behavior. That's the main message. Then the payvider, funky term as we said, that's when provider organizations, mostly hospitals and multi-specialty groups, when they own a managed care plan, an insurance plan, some kind of system that gets paid to keep people out of the hospital, strange, positive cultural things begin to occur. And we're tracking this. We've actually written subsequently after the book some scholarly pieces. But the main message today is we think that payvider, that model, might really be one way out of this jam in the future to, in a nutshell, align economic incentives to practice keeping people healthy. Instead of delivering health care services, let's keep people healthy. That's way more than semantics. And that's what we think the payvider model might be able to deliver.
In the book, David, you talk quite a bit about Geisinger and Kaiser and their successes, not just before COVID, but certainly during COVID, and what they did in terms of their management and their touching into the community.
Of course.
I'm curious, what sort of a role do you feel that data has in this sort of transition into a payvider model, particularly de-siloing a lot of the gated data that hospitals and health systems have, and then really bringing it, and helping to get it more integrated?
Great. So let's tackle Geisinger and then the data, because they're certainly related. So first of all, my good friend and colleague and great leader, Dr. Jae-Won Ryu, the CEO of all of Geisinger, their new dean of their medical school, Julie Byerly. I'm on the board of the Geisinger Commonwealth School of Medicine, real privilege. So Geisinger is in a largely rural, sort of isolated part of the world. They decided decades ago that they wanted to also be in a health plan. They represent one of the sort of golden models of the payvider, but the dilemma is that model may not be broadly applicable. Although we focus on it in the book and Kaiser as well, those are held up as sort of, if you would, a gold standard. However, it may not be applicable in downtown Philadelphia. So the real message still is all about aligning economic incentive. Now let's tackle the data. Well, you're right, Steve. One of the many challenges of the payvider, besides the culture of the provider community and the payer community, these are arch rivals. Bringing them together, not easy to do. But certainly the data structures are totally different. One organization is all focused on paying claims and has a huge amount of information on episodes of care and how care is delivered and overutilization. And another has details about individual provider performance, having access through the electronic medical record. So something that sits on top of claims and provider data that could really organize this in a way that makes more sense, where we benchmark to improve outcomes. I think that kind of data system is the data system we're going to need of the future, where no matter where you are, we could, if you would, suck out that data, organize it, get it out of the silos, and make it, in a word, actionable. So if we have actionable data, especially data that also takes into account these so-called social determinants of health, then I think we're off to the races on being able to build a much more just and equitable system.
David, I'm going to jump in here because I know Brian wants to get into the comments you've made about how we train doctors in this country, and you're passionate about that. But let's
Indeed.
talk about this technology, because you do devote a whole chapter on this issue. This is confusing to people, I think. You know, our nation, as you pointed out in the book, invented the internet.
Right.
Our hospitals are pillars of technology. And
Right.
yet, during this crisis, this COVID crisis, our computers couldn't even talk to one another.
Right.
So with all the money we spent, billions, I think $80 billion allocated during the HITECH Act to create meaningful use in electronic medical records and health information exchange, what went wrong and why does this problem still persist?
Oh, boy. Well, David Nash, as you and I have chatted about, I think if the average person on Broad Street here in downtown Philadelphia really grasped how much money Uncle Sam has spent to get the electronic medical record into every doctor's office and every hospital, I mean, it's mind-blowing for sure. And it goes back to 2008, 9, and 10, a long time ago. And I'm not the only one to reflect on this. Lots of very smart people have looked at this issue. So here's sort of the current situation as I see it. Look, certainly electronic medical records have been a very important part of our transition to be able to look at utilization, compare outcomes, drill down, compare processes, probably reduce error in certain circumstances. So there's an awful lot of positive things to say. But during the height of the pandemic, even in Philadelphia, our local health information exchange, our HIE, it turned out, had more data and a broader view of what was going on in the city than any single institution. So the ability of our HIE to just share that information, first with the hospitals, that was one challenge. And then the even bigger challenge, which is mind-blowing, is that the Philadelphia Department of Health, generally speaking, was not at all wired in to the health information exchange in any way. So while we're trying to figure out how much dexamethasone should we put people prone, when to intubate, when we're trying to answer these desperate bedside questions early on, we literally could not talk. So your observation is very accurate. Sadly, in the vaccine rollout, sharing information about who's vaccinated and who isn't. Look, I couldn't wait to get vaccinated, just like most folks. And I waited in line patiently at Jefferson. I was so relieved the day back in February of 2021 that I could get the first shot. I followed the rules as much as I wanted to jump ahead like everybody. But the point is not Nash. The point is, well, the city has no record of who got vaccinated. The state has no record. My record is at Jefferson. So I have my little card in my wallet that I have photocopied and uploaded to my phone. And this is crazy. The fact that we didn't have any kind of national infrastructure to coordinate all of this, I mean, it's unbelievable. No wonder that plane crashed. This is the 737 MAX. We knew the software was busted, and they made people fly those planes anyway. And we were lucky that more people didn't die on that plane than already had perished. Boeing knew it. We knew it. FAA knew it. Lots of blame to go around, just like in healthcare. So we need much better sharing of data. We're working hard to do that in this town. Not the easiest thing to do, certainly. But we interviewed Marty Lupinetti, the CEO of our HIE. He describes his day-to-day. He was on the phone begging people, we've got information that might be helpful. I hope you'll listen. I mean, that's crazy.
It's interesting how, you're highlighting a lot of these things in terms of the technology role, the primary care role. One thing that we haven't really talked about is public health. And as we know, there's such of a long history with public health. And when you really look and say what's made a material difference in life expectancy over the past century, it has been a lot of the public health measures.
Oh, by far and away, Brian. Clean water, vaccination, not COVID, but vaccination and clean water, sanitation, safe food. That's saved more lives than 150 academic medical centers on their best day. No question. But that's not cool. There's no temple devoted to public health. There's temples devoted to all the technology and all the cool, but there's no temple devoted to public health. I didn't mean to interrupt you, but the city, it's a perfect analogy.
Well, it's a very passionate thing because, when you really take a step back and you say, okay, what are some of the fundamental things that you could do that would have made a difference? Public health, and you highlighted too in Philadelphia, and like in most cities, and those of us that travel have walked by that public health office at the airport.
Right.
It's clear this has been incredibly underfunded, under-resourced. Right. It's not, there's no excitement about preventing something.
Right.
There's this fundamental belief, essentially, when there's a crisis, everyone jumps into action, everyone's there, whatever it takes.
Right.
But preventing it isn't really exciting. And so we'd love to hear some of your thoughts about how do we actually shift that now that this crisis has occurred, and we've all witnessed and seen the catastrophe that's occurred from it. What actually changes going forward?
Yes. Well, great. I think about, again, all the wonderful leaders who we interviewed for the book and some of my personal heroes who have influenced me over the last 3 decades. Among them, of course, is Dr. Lena Wynn, now at George Washington University and CNN. Everybody has seen her. Her great book, Public Health Has Saved Your Life Today. You just don't know it. Boy, is she right. But what you have to do is go back. I could give you the exact date when this rift started, and that's in 1965. So I'm 10 years old, and Lyndon Johnson is signing the Medicare bill in Harry Truman's hometown, right? And all of a sudden, you open the floodgates of dollars pouring in to build and create the most expensive $4 trillion a year healthcare system in the world, consuming 20% of the GDP. And at the same time, here are the numbers. In 2019 dollars, $10,000 per person, including children, annually for healthcare services. $400 versus $10,000. $400 to maintain the public health infrastructure. Back to the plane crash. Well, anybody could have predicted that system, $400 per person versus 10 grand. Well, that system couldn't withstand a pandemic. So moving forward, what do we have to do? Well, my view, which we articulate in the book, is, among other things, we need a new kind of doctor, nurse, pharmacist. But let's focus on doctors. I've been talking about physician leadership for 30 years. We need physicians who are trained in these other issues, not part of the current typical undergraduate medical education. So our College of Population Health was something I'm super proud of. When we opened the doors here in 2009, I had to explain every day what's population health. So I don't have to do that any longer. That's one positive outcome here. But seriously, I think we need to refocus both undergraduate medical education and GME to bring these tenets of public health, quality, safety, cost effectiveness. What I tell people somewhat jokingly today, I don't think we have to explain what an epidemiologist is anymore. Hopefully not. Whereas, prior to COVID, nobody could even spell that. So the rift started 1965, all the excitement, money, resources, and if you would, pardon me, the sex appeal is on the technology. The return is on the public health side. So I'm a big believer in getting this into the curriculum as early as we can to build the base of leadership who will look at public health, want to be an exciting part of it, people like Lena Wynn and many, many others. Sadly, which we point out in the book, sadly, hundreds of public health officials were under personal attack in their own communities and quit because literally their lives were threatened. I mean, this is crazy. And we tell a particularly poignant story. Right in the suburbs of Philadelphia, a local hospital-based medical director testifying at a school board hearing is shouted down. I mean, we have the videotape. Is shouted down because he said, well, I think we still need masks and we still should promote vaccinations. And this relatively wealthy suburban community, not of color, shouts this guy down to his face. So what do we have to do, Brian, to answer your great question? We have to rethink what kind of leader do we want in this $4 trillion system in the future? And I think that's very achievable. And part of the reason I'm still at it here after 32 years is I love meeting with current medical students, nursing students. We have 4 postdoctoral pharmacy students and our own students, of course. And they keep me going because when I look at them, I see in their eye, I see the future of our system, and it gives me, some confidence that there's hope, and that's really important.
David, one of the challenge areas, to shift gears a little bit, that you spoke about is something that you call the financial emergency. And, we've been talking quite a bit about, all the factors, maybe on broad levels, that have been, contributed to through COVID and exposed. And coming out of COVID now, we have the largest medical debt ever that we've ever had in the United States.
Right.
And a lot of people seem to steer clear of the idea of opening up more of a free market concept around healthcare, particularly around pricing.
Yes.
And I don't mean price transparency. I mean lowering prices, as well as being able to look at how prices are actually set, through things like the AMA's, Relative Value Unit Update Committee, which is widely unknown. What are your thoughts on, looking at the financial end of healthcare in terms of affordability and pricing?
Well, you pick another third rail, Steve. So let's just jump right in and, hold on with both hands. So look, we don't specifically cover this level of detail, but our listeners are super smart and they know the 1% in America of earners. Who are the top 1%? Well, the single biggest occupation within the 1%, no surprise, are physicians. So it's not insurance company executives, even though we could argue about their pay. But as a group, we represent the largest component of the 1%. Okay, that's very different from most of the Western world, where doctors make a handsome living, but they're not at 1%. So you could make some inferences about that price. We also know that prices that the delivery system currently charges is not connected in any way to reality as to what the true costs are and what we get paid. So the good news is that I think price transparency is actually an important step in the right direction. Certainly without that, there's not going to be any movement to examine what role price plays. Let's remember the late, great Uwe Reinhardt, right? He was all about what's wrong with healthcare? Price, price, price. Oh, and then technologic imperative, doing more to more people at a greater intensity than ever before. But Dr. Reinhardt, price, 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 that was his mantra, actually, as to what we needed to attack to lower healthcare costs. So certainly price plays a role. Who's going to be the first organization to blink? In this town, we always kid around, although it's serious, that among the best kept secrets in Philadelphia is what the largest private payer, Independence Blue Cross, pays each hospital. And that's the best kept secret. No one knows because it's secret. And that's how systems play against each other. They're in various networks. Only in America do we go back to federalism, exceptionalism, individualism. No nation would tolerate this kind of economic craziness that equals $4 trillion, where most experts agree 1/4 of the $4 trillion is of no value, and might be dangerous to boot. So, to answer your question, I do believe price transparency at least gets us on the road to starting to look at these very complicated issues. Now, in terms of what happened during COVID, let's go back to the book. Jefferson, we're grateful for the CARES money. We would probably have to close our doors, or certainly we would have laid off thousands of people just when we needed them at the bedside. So thank you, Uncle Sam, for the CARES dollars. I know I speak for every hospital. Thanks for that money. We've already spent it. I think the more important issue is, what's the model moving forward? And this is controversial. My own view is the model moving forward cannot be, let's just go back to what we were doing before. More cardiac caths and more bariatric surgery and more orthopedics and more cancer care, and everything will be fine. It will not be. And way smarter people than Charles and me know that the Medicare Trust Fund will be bankrupt in 2027 if we just keep doing exactly what we're doing. So to finally answer your question, Stephen, price is important. Let's have a conversation about it. But I think anybody could reduce cost. That's easy. Close a hospital, close a program. What leaders do is reduce waste. That's a much more difficult conversation, because in our current crazy system, one person's waste, preoperative chest x-rays and electrocardiograms on healthy people doing ambulatory surgery, as one good example. Well, that's wasteful. Lots of evidence to support it, but it's somebody else's income stream. So one of the things we got to do is disconnect the inappropriate care and the income stream that it creates. We're working hard to do that in certain places. So in a nutshell, let's have that conversation about price. I'd be happy to be a part of that. That gets us on the road to talking about waste and decoupling the procedures that are of no value, that generate income that everybody recognizes we ought not to be doing, so-called low value care. Somebody's low value care is somebody else's pocketbook. That's the problem.
Dr. Nash, it has been a privilege and a pleasure. I'm sure I speak for my co-host today as well, but it's been great having you on the show. Gentlemen, anything to add?
David, it's been a joy to read this book. And as I've shared with you personally, it really pulled together my own personal learnings over 35 years of what's wrong in our healthcare system and the things that need to be done and addressed to really get things right. And much of that I attribute to learnings I've had with you, partnerships with you. And I just think the book really helps to bring it home with such personal stories. It'll be very easy to read and meaningful to so many parts of the population. Thank you so much for your patriotism.
Thanks. Thanks very much. Really a treat to be a part of it.
David, I just want to thank you so much for being part of the podcast today and congratulate you on such of a fantastic book. I thoroughly enjoyed reading it. And one thing we didn't get a chance to talk about that was in the book, it was fun learning a lot about the different mentors that served you, and certainly want you to know that I appreciate your mentorship and friendship that we've had over the past couple decades, and looking forward to many more to come.
Well, I just want to say thanks again. I'm really grateful to you guys and to Charles Wohlforth and my whole family for putting up with us when we were working on the book. And I look forward to the feedback when the book comes out this fall. Thank you very much.
And where can show listeners and viewers get access to pre-ordering the book?
Yeah, probably the easiest place, Steve, is go right to Amazon. It's right there. Place your order, and we look forward to getting it out to you late September, early October.
Well, additional thanks today to our co-hosts, Dr. Brian Silverstein and Dr. David Nace, for their time, their thought leadership, and also their contribution. And for our listeners, don't forget to check the show notes for links to resources and contact information related to today's show. And stay tuned to the Innovation Accelerator podcast for more shows covering the healthcare IT topics that you care about. For more information on this and other healthcare IT topics, please visit Innovaccer.com. I'm Steve Ambrose, wishing you a great rest of your day.
You've been listening to the Innovation Accelerator podcast, brought to you by Innovaccer, the health cloud company. Don't forget to check the show notes for links to related resources and other information. And stay tuned to the Innovation Accelerator podcast for more programs about the healthcare IT topics you care about. Accelerate your transformation and build the future of health on the Innovaccer Health Cloud. For more information, please visit innovaccer.com.